Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. Today we are doing something special. We are discussing gaining independence in the presence of vision loss and are joined by two guests. The first is an optometrist, associate professor of ophthalmology and rehabilitation medicine, and is the director of the Lions Vision Research and Rehabilitation Center at the Wilmer Eye Institute at Johns Hopkins, Dr. Judith Goldstein. In addition, we are joined by Beth Glassman, a patient of Dr. Goldstein, who will be sharing how the low vision services helped improve her quality of life. Welcome to both of you.
Thank you, Lillie.
Thank you.
So according to the American Academy of Ophthalmology, more than 2.9 million Americans age 40 and older have low vision, which is defined as best corrected visual acuity worse than 20/40. Dr. Goldstein, what does this mean, and what exactly is low vision?
Thank you, Lillie, for the question and for the nice introduction and the opportunity to join you and Ms. Glassman today. Low vision is really a descriptive term, and unfortunately one that sort of sounds a bit scary. Essentially, when we speak about people having low vision, what we really mean is that this is a group of people who have vision loss that cannot be corrected with medicine, laser, surgery, conventional glasses. And sometimes the vision loss can be mild or it can be severe. So when people get their eyes checked, we take a lot of measurements when we see patients. And one of those measurements we call is visual acuity. And that's essentially a measurement of resolution, how small a target you can identify at a certain distance. But low vision is really more than that. It encompasses other areas of loss of function, such as loss of contrast sensitivity, where vision becomes a bit grayer. Some people may recognize this when they drive at night in the rain. And low vision can commonly come in the form of losses such as peripheral field or side vision loss. And that happens in people with glaucoma. For example, they may have trouble walking in low light or busy areas. So low vision is really this collective term that describes people who have vision-related loss and difficulty with their everyday activities.
Please explain what eye conditions actually cause low vision and who is affected and who comes for care.
People who typically seek care, they do that because they find that their vision interferes with their everyday activities. And they want answers and they want solutions. And it's often when the medical resources can't get them all the way there. But the majority of eye disease is age-related and thus occurs in older adults. So most of the people that we see are affected by macular degeneration and glaucoma. But because vision loss doesn't discriminate, we see people of all ages, young children, working age adults with all kinds of conditions. Some are hereditary in nature, such as ocular albinism or Stargardt's maculopathy or retinitis pigmentosa, and others have neurologic-related loss, such as strokes or brain tumors. So it's not so much the condition or the acuity that drives people to seek care, but rather these people who need ways to improve their quality of life.
Some of those diagnoses are certainly quite serious, too. Beth, I understand that you're a patient of Dr. Goldstein. How did you find Dr. Goldstein and the Low Vision Center?
Well, that's what's so amazing about this whole story, is that I found her totally by accident. And that's why I'm so grateful that you're doing this podcast so that people like me with low vision can know about this valuable service because it's not publicized enough.
And how long ago did you find her?
Oh, it's been about 10 years.
I understand, obviously, that you have low vision. What are the challenges for you or for someone else who also has this same type of issue?
Low vision, of course, affects everybody in a different way, but I would categorize it basically in three different areas. First, your independent living skills are totally upended. So let's take an average day. You wake up in the morning and you go to brush your teeth. You take off the cap of the toothpaste, which is white. You place it on the countertop, which is white. People with low vision have very poor contrast. As you fumble around, the cap falls on the floor, that's white. Now you're on your hands and knees looking for the top of the toothpaste. You then go to get dressed. People with low vision have trouble with color. So you can't discern, are the pants gray, black, brown, green? Same with your shoes. Then you venture into the kitchen. Try to make a cup of coffee. You can't find the outlet. If you're lucky enough to feel it, you make the coffee and you burn yourself because you can't see the coffee in the mug. You go to open the refrigerator, the light in the refrigerator blinds you. You can't find anything in the refrigerator. It means you can't preheat the oven to 450. You can't set the thermostat in your house. Can't use your washer and dryer. So every aspect of your life is upended, and you can see how frustrating this is. And you haven't even started your day. The next area would be mobility. As you enter the world, it's a very dangerous place for a low vision person. We know that falling is a very bad thing. And people with low vision have depth perception problems. So stairs and curbs are extremely dangerous, and they're not accompanied by railings. Now we have, in addition to these issues, we have scooters that are strewn across our sidewalks, and we have curb cutouts. And if they're not accompanied by a tactile bump, a person with low vision doesn't know if they're safely on the sidewalk or still in the street. And crossing the street can be also difficult because there's no audio signal. And finally, the world is connected now by technology. And for people who can't read, we're left out. But what I want to say is in each of these three areas, there is help. This is what the Low Vision Service does. They will give you tricks. You learn how to overcome these obstacles. Does it take a little bit of time? Sure. But I don't want people to end up staying at home because they're fearful of going outside. I want people to enjoy their lives fully, and it's totally possible with the help from the Low Vision Center.
So you gave excellent examples of how disruptive low vision is for an individual. And I think that until someone listening to this podcast actually ponders this for themselves and for their family members, maybe their parents, brothers and sisters too, that this probably hasn't hit their radar screen. Because if it isn't happening to you or someone that you love that perhaps lives with you, then you don't think about it and you're frankly not very aware of it. But what you just described is total disruption to someone's quality of life and their inability to be living in harmony with this disease rather than just merely, frankly, existing. I can certainly imagine that people would be afraid to go out, saying, I just better stay right here in my house and fumble around as best I can. I also think that it sounds like it improves your efficiency. So rather than spending quite some time in the bathroom, brushing your teeth, having to find things and get things and find the cap on the floor, etc., that you can brush your teeth now rather efficiently and do other things in your home as well as outside of your home. And I hate rework and I hate processes that slow me down. So I can truly see how this has turned your world around in a very positive way. Dr. Goldstein, how does low vision rehabilitation work and what types of interventions are available? We usually think about rehabilitation when we're talking about physical therapy and occupational therapy of someone exercising their arms and legs. And obviously, that's not what we're talking about this time. We're talking about low vision rehabilitation.
So I think that's a really good parallel, right? This is really rehabilitation and not restoration. Similar to other types of medical specialties, low vision rehabilitation has this evaluation and a treatment component. And the evaluation starts with an extensive patient interview because the treatment is really individualized to the patient, the person. And the doctors and the therapists have to know everything about that person. What are their goals? What is their unique situation? Do they want to be able to see, to read better, to drive better, to walk more safely? And so we have to have a knowledge of not only that person's interests and goals, but what's their lifestyle like? Are they a student? Are they a parent? What's their support services? What's their physical health, their cognitive health, their emotional health? So all of these aspects make up the patient. So once we get to learn about the patient, we then take a ton of measurements that are typical for an eye exam, right? Things like visual acuity and contrast and visual field. And then we have a fairly good understanding of the patient's state, and we can begin to offer treatment strategies. And treatment generally falls into one of three categories. It might be the vision enhancement part, where we may prescribe specialized or strong glasses. In some cases, it's just simply updated glasses with some thoughtful consideration to maybe what the form the lenses might take. But enhancement can also be done with what we call visual assistive equipment, such as near magnification devices or telescopic lenses, or even electronic tools. And so much like what you were saying before, we evaluate the efficacy of these interventions during our visit. The other two categories include sensory substitution and education and counseling. And in sensory substitution, we teach patients, we train them to employ their other senses to accomplish a task. In the case that Beth spoke about, in that case, I would tell a patient to squeeze that tube of toothpaste right on their finger and put it right on their mouth, right? There's no point to have to put it on the toothbrush. But we've advanced a lot. And so where it used to be, we'd be talking about talking watches or listening to news read to you over the phone. Today, it's more about asking Alexa, read you a book, or Siri to speak a text to you. But, I would say one of the key components to vision rehabilitation is the education and the counseling piece. Many people with vision loss, they don't understand their condition. They feel isolated. They feel unsure about how to cope with their loss. And so much of our time is spent in conversation with the patient, counseling them on the steps they need to take. And we're fortunate in our field because a visit with a patient typically is an hour face-to-face with the doctor or the therapist. And so time really permits us to focus on the areas that the patient needs.
That's excellent. If someone is looking for a low vision rehabilitation, do you need a referral?
It's a good question. So a referral is actually not required at all for an evaluation with a low vision physician. The services are covered by Medicare, private insurers. It's the same as seeing any of your other eye doctors. But because we are in a rehab team setting with occupational therapy and rehab therapists, for some patients, a referral to those therapists may be required, but that's something that happens internally. I think most importantly, people need to understand that you can simply seek out care, make an appointment, and on the back end, we obtain the medical information that's needed. And some people want to know, how much do I have to commit to this? And what I often tell people is, come for one visit, see what's available, and then let's decide what's really needed.
That's wonderful. And that's a barrier that's actually being removed then, because commonly when you need to get a referral, then you have to see another doctor and you wait for an appointment. And it can go on long enough that sometimes people just give up. Thank you for making this an easy access program as well. And it's wonderful that it is covered, including by Medicare, which sometimes they don't cover things. Dr. Goldstein, what areas of research are underway in vision rehabilitation?
So there are many areas. I'll touch on two that I think are really important. Some of the research surrounds the development of vision enhancement technologies. You may think of these as these head-mounted displays or these virtual reality headgear that have these built-in smartphones. And there's been a lot of advancement over the past 5 years. And our current work at Hopkins focuses on the development and testing and training with these systems using these devices. But these devices are also commercially available. So from a patient perspective, they can use them, but many of them still remain big and bulky. And with few exceptions, they're really not able to walk in them. I anticipate that a lot of this head-mounted technology will improve dramatically over the next 5 to 10 years, and we'll all be walking around with little glasses with cameras in them. And then it maybe won't be so odd or different. The other area of research that I'm really excited about is what we call implementation science. And that really focuses on the delivery of services to everybody who needs them in a more efficient and effective way. And we're excited about this work because we've recently completed a project where we incorporated user-centered design, looking at physician behaviors, clinical decision support tools, and electronic health record technology to connect patients to care. We think that this work not only has applications within ophthalmology for care delivery, but throughout all of medicine, so that everybody gets this individualized care based upon their findings. So we're excited to expand some of that work and look forward to really improving the quality of life of people who need it.
Why have so many of us never heard of low vision rehabilitation doctors and therapists?
There are few low vision physicians across the nation, and that's one of the major reasons. And the economics of the profession are challenging, right? We only see a few patients in a day because we spend so much time face to face with the patient. So finding a comprehensive provider might require a little research, a little talking to your eye doctor. And sometimes patients may not be told about rehab services because there are time constraints in a busy practice. And physicians are often focused on medical management rather than the functional aspects of patients. One of our aims at Hopkins is to address this problem of the lack of subspecialists across the nation in low vision. So we developed a partnership with the Lions of Multiple District 22, and we developed a 1-year fellowship training program where each year we train one physician after their low vision residency program to complete a fellowship, thus increasing their expertise in the area, clinical and research, and then they go on to lead programs, right? And they train more people and so on and so on. And so we're really excited about this because we think that with time, we will develop more experts who will train their proteges and we will make it more accessible.
I know in nursing school, and I started nursing school, heaven forbid, this summer it'll be 50 years ago, that one of the things that was done that long ago and is still done today is to provide student nurses the opportunity to experience what it's like to have low vision, where we will wear glasses that will definitely distort our vision and kind of fog up everything in front of us. And then we're given assignments of find thus and so there on the table and take this lid off without spilling the water and doing other such things. I'm curious to know if this one individual that you're talking about that's trained each year, do you do that type of experience for them so that they can truly be empathetic and have a clear personal understanding of what it's like to have low vision?
So we use simulations or simulator goggles a lot. We use it for family members, friends, support networks, those types of people. With our fellows and our trainees, I think by their very nature, by coming into this subspecialty, they are so empathetic that they have already sort of had a very good understanding because we spend so much time listening to patients that I think we ourselves in many ways prepare ourselves for what may be in the future, right? So I walk down the steps and I hold the rail. Right? I do things now that I know that my patients have challenges with. And so I think those types of things are very helpful for family members and friends.
Beth, is there a message you want to give to others whose sight may be compromised?
Yes, and thank you for the question. I'd like to return to something that I think is very important, and that is refraction, which is a big part of your visit when you go to the low vision center. A person with low vision should really be refracted by someone with low vision training. Everyone who wears glasses or contacts has had a refraction, but a low vision specialist has special training. So for instance, my glasses that Dr. Goldstein did, I wear bifocals. And the purpose of the bifocal is to help me see the food on my plate. May not seem like a big deal, but in the salad, if I see something red, I'm not sure if it's a cherry tomato or a beet. But how I address that red thing is going to be very crucial for my dining experience and those of others around me. And Dr. Goldstein actually has done research that a low vision specialist who does a refraction can yield up to a 2-line increase on the visual acuity chart. This is really, really important. For instance, I am looking at someone in front of me, and all of a sudden I can recognize a face. I can see sunrises and sunsets and rainbows. I can go back to an art gallery or a ballet. A very good refraction can have a big impact on the person with low vision. And I think this is another very important area where a low vision specialist can help restore some normalcy in your life.
That was perfect. Thank you ever so much. Dr. Goldstein, share with us what advice you would give patients who may have some problems with their vision, but may not actually be considered as having low vision.
There are many solutions available to people with any level of vision loss. So about 1/3 of the people that we see have very mild impairment, better than that 20/40 that the Academy of Ophthalmology describes, because maybe they have contrast loss or visual field loss. So the solutions we have are simple and complex, but I think what's important for people to understand is that it may not mean restoration or recovery of vision. So finding an expert and understanding how best to address the problems that the individual has, whatever the level of vision loss, is the first step. And I think being informed is powerful, but developing adaptability skills, being taught those skills to do things differently, may be even more meaningful in a person's daily life.
And we certainly are talking about quality of life in an incredibly significant way. In preparing today for this podcast, I was reflecting back on an ophthalmologist that was one of my family's very closest friends, and he was a Johns Hopkins ophthalmologist. His name was Dr. Richard Hoover. When I was in nursing school, as I mentioned, 50 as in 50 years ago, each of the physicians that would come and teach us about a different organ. So, your heart is your most important organ in your body. The pulmonologist would say your lungs are the most important organ in your body, and your pancreas is the most important organ in your body. So every single person that came said that, except for the ophthalmologist. And the ophthalmologist just talked about vision loss and blindness and glaucoma, etc. And when I saw Dr. Hoover over that weekend, I told him about my experience because he was always asking me, what did you learn this week in nursing school? And so I told him about the eye doctor that had come, and he said to me, he didn't tell you that your eyes are your most important organ? I said, no, sir, he didn't. And he said, let's think about this. We take in the world through our eyes. We express ourselves through our eyes. He said, you always remember your eyes or your most important organ. And I've never forgotten that. So as we close, ladies, are there any final words that you would like to leave our listeners?
I would say that apropos to what you just said, that you should treasure your sight. Everyone should go get an eye exam once a year. Anyone who has problems with their vision, take your drops, get your shots, do your follow-up appointments, listen to your doctor. And if you have low vision or have lost some sight, there's help out there. Call the Johns Hopkins Wilmer Low Vision Center and make an appointment. I promise you will learn something that will help you in your life. We don't want low vision people to be at home and be afraid of going outside. We want all of our citizens to be able to gather and have a full and joyous life. And there is hope and there is opportunity. So please take advantage of this wonderful service.
What an excellent example you are of that service too. And Dr. Goldstein, any parting words?
Sure. Just to parallel what Beth said, I often hear from patients that they have been told that there's nothing more that could be done. And from a surgical standpoint or a medical standpoint, that may very well be true. But what they often don't walk away with is the knowledge there's a lot more to offer with making the better use of their vision, that they can do things differently to make their life easier. And so everybody who has vision loss wishes there was more that they could see, but there are many ways that they can do more and have a better quality of life, which is ultimately really what matters.
Thank you both so much for joining me this morning.
Thank you so much.
Thank you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lillie Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/awomansjourney. Like us on Facebook and Twitter and visit our website at hopkinsmedicine.org/awomansjourney. Until next time, stay well.